All right, so now we got our movie working, so you can see the mechanism of cam impingement. Let's have a look. So when the patient flexes, if they have a bump or dysplasia, the bump rams into the anterior labrum and then eventually penetrates and involves the hyaline cartilage. There's a magnified view of it. So here's the cartilaginous and osseous portion, the so-called inside-out abrasion, and then the labrum eventually will detach. It'll split and detach. All right, let's see the next one. Pincer impingement. Overcoverage. Hip flexion again, but since there's overcoverage, the head is driven backwards. Now the neck is thin, so the neck actually gets hammered by the labrum. The labrum does tear, but it's a direct impaction rather than a shear effect. So you'll get edema here, and look at how the head is pushed backwards by this long, droopy anterior acetabular wall. And eventually, they develop extensive posterior labral tears, and they kind of meet in the middle. So the whole thing will be involved, but it is very posterocentric in terms of the chondromalacia. Okay, let's look at our next case now. Okay, we're on case T203, 60-year-old with prior hip replacement. Man. So you all have different scanners. You've got things like CMAC and MARS and all these metal correction softwares, which are nothing more than fast spin echo imaging. Very thin slices are advantageous. Altering the bandwidth, usually raising the bandwidth a little bit helps. And then they have various corrections in plane and through plane phase encoding corrections, which differentiate some of these sequences like Maverick, Mars, and CMAC. Now, the amount of artifact you get is dependent upon what the prosthetic is made of. Titanium's the best, steel's the worst, cobalt and chromium are not so good. Not as bad as steel, but they're pretty bad, so they can give you a lot of artifacts. So frequently what you're looking for is an effusion and the character of the effusion. So you want to decide, do you have particulate in the effusion or do you have metal in the effusion, so-called metallosis? Now the whole entity, the enterprise of developing an inflammatory response to a prosthetic, especially with lymphocytic infiltration, is called ALVAL, aseptic lymphovascular associated lesion. But it's not a lesion, it's a process. So you really should not really, you should not have these large coalescent effusions after a replacement. So there can only be, several possibilities. Septic arthritis. And in septic arthritis, you're going to see extensive soft tissue swelling, and you'll usually see either reactive or destructive bone marrow edema somewhere. Also, the clinical will help. In particulate disease, you'll see intermediate signal intensity. In metallosis, you'll see low signal intensity that blooms. So let's have a look at this case. I'm going to put it 3 up. I've got my axial, I've got my coronal. They did a gradient echo. It's totally worthless. They had no business doing that. You don't do any gradient echo when you have a hip replacement. That's a waste of time. If you're going to do T1 spin echo, it's advantageous to use very thin sections. They did a PD. Probably not a good idea. So the fast spin echo They did a couple things wrong here. The slice thickness should have been 2, not 4. Would have made the images look a lot better. And they should have used a longer TE instead of a PD. Let's see if we have a true T2. Yeah, they did everything wrong here. Use too short a TE. You want T2 fast spin echo in this case. You want T1 fast spin echo. You want thin slices. You want a higher bandwidth. And if available, you want to use one of these through plane or in plane phase encoding modifications called CMAC Maverick or Mars. So have a look. Now, one advantage of having at least one gradient echo, even though it just makes the image look awful, is if you have a huge effusion, it will help you detect metal. It'll help you see blooming. So let's have a look. And do we see the black signal of blooming, the black signal of metal? And the answer is no, we don't. We see more gray signal everywhere, including in the tensor fascia lata space. This bursitis and capsulitis has dissected out into the lateral soft tissues. All of this tissue here represents particulate disease, reaction to the liner that is used in the prosthetic. And the treatment, unfortunately, is going to have to be removal of the hip replacement and replacing it with something else to which the patient doesn't react to. So this is a manifestation of ALVAL, aseptic lymphovascular associated disease or lesion. This is the particulate variety. Patient is not septic for reasons that we've already ascertained, and I've given you some parameters to augment your study. Now, if you are at all concerned about osteolysis, the T1 is going to be your best friend, so you want to look for hypointensity around areas you can see, but a better test for osteolysis is thin section CT with reformatting. So if that is a concern, then CT is a better choice. But you can see it on MR. T204, 20-year-old with left anterior hip pain following a soccer injury. And then we're off the hip for good. So I've got a bilateral, I have an axial, and I have a coronal water-weighted image. Only 20, pretty young. This is not an easy case for our last one. I'll help you out and tell you there are two findings here, one of which was missed. Not by me, although I have shown you some that I've missed. We double read a third of all our cases. So out of the 1,500, 500 get double read every day. Since it's so difficult, I'll give you just another minute, and then let's discuss it. Now remember the 155 kilogram man that couldn't get a leg drive and ended up having a labral tear, and the orthopedic surgeon wanted an arthrogram? This is a similar case, but even more subtle. Right there. That was missed. There's a second finding. See if you can identify it. So he has a labral tear. And that labral tear is not visible in the sagittal projection. It's not even visible in the radial, because the radial is parallel to the tear. Never really got very perpendicular to it. They also didn't put the radius in the middle of the hip, so it was done improperly. Okay, so I'll take the suspense away. He has a bifid iliopsoas tendon. There's two of them. Twins. And inflammation, too, between the two of them and around the lateral one, which is typically what you see in iliopsoas snapping tendon syndrome, which he has. Now, sometimes you'll see a ridge. Sometimes you'll see anomalies. Sometimes you have to ultrasound it and follow the area where it snaps over the anterior ridge. The sheer diagnosis of it is probably made quite well on MRI by seeing the swelling, but the actual management of it requires dynamic ultrasound imaging, not MR. So two problems this young man has. This young gal has: an acquired labral tear with a very early paralabral cyst, and a bifid iliopsoas hip flexor with active inflammation or peritendinitis and snapping tendon syndrome. Now, those can sometimes be treated with injection. They're even starting to use PRP and stem cells on them. And sometimes they actually have to go in and free up the tendon. There's often adhesions there. And sometimes they'll even do an acetabuloplasty. The question is this too subtle to call? Let's see, I'd need to look at it. No, I don't think so. I don't think it is too subtle to call. I think it is part of the patient's labral tear. I think that's an excellent observation. This one. And I think they match. If they don't match, they're one cut off, right? It's on the very next slice. So no, I don't think so. I think it's an excellent observation. Let's see how it relates to his other labral tear. Yeah, it's probably extension of that same tear. Let's see. Yep. It's extension of that same tear. Now, the area below it is a recess. That's a recess. That is the tear. That is a tear. So, yes. Thank you. Shall we move on? It's a terrific, subtle case. On to the ankle, the land of tendons. So not many of you are ankle aficionados. A lot of you may run away from the stack when the ankle shows up there. Start out with a discussion of anatomy and my approach, to the ankle. So I'm going to begin with usually the collaterals. So I'll take them collateral by collateral. The most commonly torn collateral is not the calcaneofibular ligament, it's the anterior talofibular ligament. And if you plantar flex the foot, it may be a little more difficult to see, but it makes the tendons easier to see. Then we've got the second most commonly torn ligament, which is the calcaneofibular ligament. It goes from the calcaneus to the fibula and forms the floor of the perineal fossa. Then we've got the almost never torn posterior talofibular ligament in the back. Never tears unless you have an ankle dislocation. And then you keep on going up higher to see the high ankle, which includes the anterior tib-fib ligament, the posterior tib-fib ligament, and the interosseous membrane and/or ligament, which is perforated by small vessels and nerves. And these tear in an intercalary fashion. And when you have high ankle injuries, you typically have a lesion along the back of the medial malleolus, down lower in the tibia. And you'll have various signs that we described before, the Shaput and Volkmann sign, which we'll see in a few moments. So now we go over to the medial side, and a coronal is probably most advantageous for the medial collateral ligament, which uncommonly tears. But when you invert your ankle, you're going to compress the deltoid, and it's going to swell, and you may tear some fibers. But you know what? So what? Nobody should be operating on the deltoid. If you've got a clinician that's done 5 deltoid surgeries last year, run away from that clinician. It heals really well on its own. Very rarely is surgery required. Now, the medial collateral ligament consists of the easy deep deltoid fibers, which consist of the posterior and anterior deep deltoid fibers. And then you have the superficial MCL, which consists of fibers that go along the superficial aspect of the deltoid towards the calcaneus in the back. And then as you come forward, these aren't particularly thin slices, but as you come forward, you'll run into the tibio-spring ligament and the tibio-navicular ligament, which we can't really see here. So you've got a superficial layer and a deep layer. So it goes tibial spring, then tibio-navicular, then tibio-spring, then tibio-calcaneal is the order. So here's the navicular. Maybe that's the tibio-navicular, that's the tibial spring, and that is the tibio-calcaneal ligament. In fact, I think it is. There's some more of the posterior superficial deltoid. You're also going to have an anterior and a posterior superficial component. So taken in total, there are about 5 to 6 different components of the superficial layer. But on top of that layer sits the laciniate ligament right here. Now that is not a true ligament. That's just the medial retinaculum. Let's see if I can spot it in the axial projection. There it is. So deep fibers of the deltoid, superficial fiber of the deltoid. Let's see where we are right here. We are at the level of the tibio-calcaneal ligament. So you can see it's hard to separate out from the deeper fibers in the axial projection at this resolution. But again, I don't get too enamored with it because I know it gets injured in inversion. I know we don't operate on it. I only get excited if I see a fracture or I see fibers that are completely transected and bent upon themselves. The next search pattern are the tendons. The tendons are going to curve. So you have to be perpendicular to those tendons. So if the tendon runs like this, then your axial should run like this, not orthogonal. Otherwise, you're going to get magic angle effect and you're going to get fooled. We've got 4, 3, 2, and 1. 4 in the front, the tibialis anterior, the extensor hallucis longus, the extensor digitorum, and peroneus tertius, sitting atop the neurovascular bundle, which includes the anterior tibial artery and the deep peroneal nerve right there. Then you've got 3, Tom, Dick, and Harry, the posterior tibial tendon, the flexor digitorum, and the flexor hallucis, with the posterior neurovascular bundle, including the posterior tibial nerve, which as you go distally will split into a medial and lateral plantar nerve, and there they're splitting. Medial plantar nerve, lateral plantar nerve. Let's make them just a little bigger so you can see them. They're traveling with the posterior tibial vascular bundle. And they like to stay close to the flexor hallucis and flexor digitorum, known as Henry's master knot. So now let's go back again. Got the cineate ligament on top, the neurovascular bundle in the back, the flexor hallucis, and this area is known as the tarsal tunnel. This area is known as the anterior tarsal tunnel. Now let's go over to 2, the peroneus longus and brevis. So let me put up my axial T2 so we can sing along together, T2 and T1 in concert. So we start up high where we see the musculotendinous junction of the peroneus, and we keep going down, and we should have only 2 structures here, the peroneus brevis in the front, the longus in the back, and the superior peroneal retinaculum, but we have an extra structure that's inserting on a bump on the calcaneus. Could that be a tear? Well, no, it's not a tear. It's going right back up to the peroneus musculature. It's an accessory tendon called the peroneus quercius. So don't be misled or confused by that. There's actually more than one accessory muscle or tendon in this case. There's also an accessory abductor hallucis in this patient. But pay no attention to that. Let's keep going, shall we? We're going to look at the square shape of the talus, and then we're going to look at the square shape of the distal tibia. Then in the axial projection, finally 1, the Achilles. Now let's turn our attention to the sagittal projection. Now, admittedly, he has an abnormality. He has stress reaction at his navicular. He's got an os tibiali externum or os naviculari syndrome due to traction of the posterior tibial tendon on this accessory type 2 synchondrotic navicular, producing edema due to micro instability and motion. But that's not why I'm showing it. And here's our friend Tom, and there's Dick, and there's Harry. And there's the neurovascular bundle that's going to split into a medial and a lateral plantar nerve and also give off a sensory calcaneal nerve. We've also got quite a few veins and vessels in the neighborhood. The sagittal projection is a great one to look at the relationship of the talus to the calcaneus, to look for fibrocartilaginous coalitions and dysplasias and erosions and arthropathy. When you're all the way off to the medial side, it's called the sinus canal. And in the sinus canal, you've got an obliquely oriented ligament. You can see it right there. That's the talocalcaneal interosseous ligament. We may see it better in the coronal projection. But as we get a little bit further out, we see a much more robust ligament right here, which represents the cervical ligament, which is the main stabilizer of the subtalar space. And then as we get all the way out, we see the lateral retinaculum, which has a bursa that travels with it called the stem ligament bursa or the frondiform ligament bursa. So 3 ligaments from medial to lateral. The talocalcaneal IOL, let's see if we can pick it up. We can, right there. The cervical ligament, it looks a little squishy, but it's right there. And then the retinaculum is very wispy in this patient, and so we'd only see it on a T1 weighted image, not on this water weighted sequence. Then we'd look at the bony architecture to make sure that the talus is not excessively round, that there's no OCDs. There is another set of ligaments between the high ankle and the low ankle called the transverse tarsal ligaments, and probably a little bit beyond our scope of discussion today, but they bridge between the high ankle ligament and the low ankle ligament. So there's a transverse tarsal ligament, and there's an oblique transverse tarsal ligament, which we don't see in this particular example. We also want to look at the relationship of the sustentaculum tali and the middle facet to be sure that we don't have a bony or fibrocartilaginous coalition. This is also a reasonable projection to assess the plantar fascia to see if the patient has inflammation at the origin. They do not. Or to see if there is tumefactive fibrotic proliferation, as in Lederhauser's disease or plantar fibromatosis, which is extremely common, and the kissing cousin of Dupuytren's contracture. So that would be the basic search pattern for the ankle. Now, if I'm in the foot, I'm going to be looking at the Lisfranc ligament, the metatarsal shafts, and the plantar plate, and that'll be a story for toe and foot evaluation. So this patient has os naviculare syndrome. There are 3 types of os naviculare. One type where you have a navicular, and it's a normal looking navicular, and then you have a nice round structure that's located in the tendon. That's called os tibiale externum. Those are usually not problematic. Then you have a navicular that is arcuate shaped. In other words, it has a hook to it, like this. It's connected. It's all one bone. And then you have this type, type 2, which is the symptomatic type, where you have a synchondrotic interface, an excessive movement of this structure relative to that structure. This gets swollen, and so do the bones. It often simulates posterior tibial tendon tear. So I go at it by tissue. Ligaments, I systematically pick them off one by one. Retinacula, I showed you the medial and lateral retinacula. I forgot to mention the Achilles, tendon number 1, but I go tendon number 1, peroneus longus and brevis 2, posterior tibial tendon flexor digitorum and hallucis 3, and then anterior, the tibialis anterior, extensor hallucis, extensor digitorum, and peroneus tertius. So with that, let's dive into some cases. Anybody have any questions about anatomy? We're going to see the individual fibers of the deltoid better with higher resolution imaging as we kind of course through these cases, and I'll point it out to you. 15-year-old male, medial and posterior ankle pain since an injury earlier in the year. So it's a child. I usually start my feet out with the sagittal because I like the lateral conventional radiograph. I grew up on it. I'm comfortable, very comfortable with the bony architecture and anatomy. So up it goes. Sagittal T1, sagittal gradient echo for cartilage and bodies, and sagittal PD spur for detection. Now, the history. Earlier in the year, that's pretty darn important. Now, all children get spotty, dotty, ill-defined hyperintensity from running around and abusing their feet because they're going all day long. But they should not have peripheral patterns of edema or coalescent patterns of edema. They should definitely not have every single bone etched in white, including the calcaneus. That is hugely problematic in a child. Let's look at the coronal. Same thing. Some of you would say multifocal stress injuries, and you'd be 1/10 right. Let's look at the axials. Look how much more impressive the PD and the T1 are when compared with the T2. That is not all that water sensitive. There's no soft tissue swelling to speak of, maybe a little bit. And hopefully you come up with a diagnosis by now. I'm going to go back to the coronal and see what kind of anatomy pops out while you're looking. We get a beautiful separation of the superficial deltoid layer from the deep oblique deltoid layer. So in the back, the tibiocalcaneal ligament. In the front, a little tougher. Actually, I was in the front. That's the tibiospring ligament right there. More tibiospring ligament. In the back is the tibiocalcaneal ligament right there. So we can see at least 3 of them. Now the tibiospring ligament has a very round configuration. The tibionavicular ligament, very thin and very small and very hard to see without 1 or 2 millimeter cuts. That may be it right there. But that's not why we're here. I'm digressing so you can decide what's wrong. It's a critical case. Because if you decide wrong, it's a disaster. They can lose their foot. Patient has RSD. This is what RSD looks like in a child. In fact, this is what RSD looks like in most people. No, it's not soft tissue swelling. That happens at the end, not at the beginning. In the beginning, it's marginated subcortical osteoedema. This child needs to have a lumbar block or multiple lumbar blocks on the side, namely the left side in the lumbar plexus. That's the treatment. Sometimes they even have to have an epidural placed and have their foot manipulated and moved because they won't let you touch it. You go to pick up their foot to put it in the x-ray and they say, no, don't touch it. As soon as you hear that, RSD. This is RSD. So it's been broken down into complex regional pain syndrome type 1 without any neurologic involvement and type 2 with neurologic involvement. This one did not have neurologic involvement. Type 1 is about 8 to 10 times more common than type 2. couple of other little pieces and tidbits of anatomy. Coronally, we can see the posterior talofibular ligament. We can also see the origin of the calcaneofibular ligament, which is very oblique, so it's hard to pick up in the coronal projection unless you angle it. And then in the axial projection, let's look at the anterior talofibular ligament, which is beautiful. That's about the proper thickness for it. Here's the posterior talofibular ligament. And let's see the calcaneofibular ligament if we can pick it up at this angle. Probably not. We don't see it well in this angle. So we see it a little better coronally. Are there any questions about this case? Question, Matthias. There is a coalition. Stole my thunder. Just going there. There is a coalition. It's a fibrocartilaginous coalition. And so that might make you think, well, these are all stress reactions. And I was just about to show you this dysplasia. Look at how this is curved upward as opposed to flat. And then you can see this weird interface in the posterior facet. And then he's got a well-defined talocalcaneal interosseous ligament. And this time we better see the cervical ligament and then the extensor retinaculum. So this one shows the anatomy a bit better. See, the talocalcaneal IOL goes this way, and the cervical ligament goes this way. So with that coalition, you're much more apt to call this something stress-related, and maybe this part of it is related to the altered mechanics of weight bearing, but not the rest of it. It's an interesting one. Okay, and a very important one. What else would give you subcortical or juxta-articular edema? RA, JIA, anything that inflames the joint. So that's a pretty easy decision tree. RSD, we don't use that term anymore, but the clinicians like it. RSD versus JIA or RA, no problem, right? RA, synovitis, erosions, pannus, shouldn't be a differential diagnostic dilemma at all. 1, Achilles. 2, peroneus longus in the back, brevis in the front. 3, posterior tibial tendon, flexor digitorum and flexor hallucis. Tom, Dick, and Harry. 4, tibialis anterior, Tom. Flexor hallucis longus, Harry. Flexor digitorum longus, Dick. Tom, Harry, and Dick, carrying the peroneus tertius with them. And as I mentioned, I like to have the sagittals up first, so I'll put up the sagittal water-weighted image. In fact, I'm going to put up the sagittal T1 image with it. Full thickness tear of the Achilles. Let's go up there. That's an unusual one, right at the myotendinous junction. Let's make it bigger. Where do they usually tear? About 2 centimeters above the heel. The footprint of the calcaneus is rather large, so let's delve into some anatomy. It's very broad. The deeper fibers are usually more soleal in contribution. The superficial fibers are usually more gastroc, although there is twisting of the two heads, the medial and lateral head, as they descend, and then they come together and coalesce as one. We'll look at the pre-Achilles fat space, so-called Kager space. We'll look at the superior calcaneal protuberance to look for a Haglund deformity, which he doesn't have. And then we'll make sure he doesn't have any other posterior heel problems like plantar fasciitis or ostrigonum syndrome. And he doesn't. So let's go up to our full thickness tear. Really? Full thickness tear? Well, you know what? It is a full thickness tear. It's just not a complete tear. right? Remember, length, width, depth. So is it full depth? Yeah, it is. It's just full depth in only one half of the Achilles. So do you want to trick the clinician? Of course not. You want to tell the story. The medial bundle of the Achilles has a full thickness tear with diastasis of X, with swelling of the distal component, while the lateral bundle is preserved. That's the way to say it. Now they know what you're talking about. What would it be if it was complete, all the way from side to side? Depth, length, diastasis. Anybody have any questions on this one? That's too bad, because there's some other findings here. Matthias saw them in the last case, but what's going on here? Something got sliced, right? I mean, look how sharp edged that is. 22 years old. You can't tear that, with a sport injury unless you get cut. So what do you get cut by? A skate. And some of you may have seen the video of, I believe it was a Dallas Maverick maybe, that got cut with a skate in the neck. They saved his life. He had a carotid transection. So our friends, I think it's Dick and Harry. Let's see. Oh, it's Tom and Dick. Tom and Dick, the tibialis posterior and the flexor digitorum are cut also. And you can see the skate penetration right there. So they cut half the Achilles. Let's check out the axial to corroborate who's been cut. Tom, Dick, and Harry. There goes Dick. There goes Tom. There's Harry. There's a vessel. There's the posterior tibial tendon artery. So that's okay. Thank goodness. And there's the nerve right behind it. So they didn't cut the nerve either. Neurovascular bundle. Don't forget to check it. A 56-year-old with chronic lateral ankle and foot pain and progressive swelling, limping, and occasional instability. I don't know what that means. Occasional instability. I guess that means when you step a certain way. So I'll do what I always do. I put up my sagittals first. I've got 2 of them. I'll make them a little bigger. And thank you for the reminder. Much appreciated. "56 years old. Well, you could pretty much take any pulsing sequence you want. It'd be nice to have a gradient echo. I don't think we do. Because if we had a gradient echo, it would show more advantageously what's going on. Now you might say, well, that's a plain film diagnosis. No, it's not. It's not going to be calcified most of the time. You'll see erosions. You'll see a swollen ankle, and you'll have no idea what's going on. But on MRI, there's only one diagnosis, right? It's a mass that's producing pressure erosions. It produces the biggest pressure erosions in the joints with the smallest capsule, because they're the tightest. And what are the 2 joints with the smallest capsule? For bone size, elbow and hip. But the capsule of the ankle isn't all that big. And we've got plenty of pressure erosions with heterogeneous low signal intensity throughout that would have gotten a lot lower if we had been fortunate enough to have a gradient echo image. We don't, but we make the diagnosis of pigmented villonodular synovitis, multifocal or diffuse variety or type. Now, what does MR add besides telling you what it is? A lot. Because how do you treat this? Got to do a synovectomy. How do you get there? Depends where it is. So the portals of entry are dependent on the MRI. You may have to go in from the back, subtalar, from the back, from the front, subtalar. You may have to have 5, 6, 7, 8 portals of entry to get this done. In some centers, they'll use yttrium, a beta emitter, to try and treat it when it is unresectable. But most of the time, synovectomy is the treatment of choice. This is PVNS, which is histologically identical to giant cell tumor of tendon sheath. What are the other synovial metaplasias? This is the most well-known synovial metaplasia, but we've got synovial chondromatosis, primary, which can undergo dedifferentiation and become malignant, and secondary, due to irritation, never undergoes dedifferentiation. We've got lipoma arborescens, fatty metaplasia. We've got synovial hemangiomatosis, vascular metaplasia. And we've got synovial osteochondromatosis, in which you see osseous bodies, sometimes commingled with chondral bodies. The process can be focal or it can be diffuse. Any of them can be focal or diffuse. When it's focal and it's PVNS-like, some refer to it as intra-articular giant cell tumor of tendon sheath. Let's scroll it one more time. It's just too beautiful to waste these images. Let's blow it up just so you can see it coronally. And look at the pressure erosions. Look how impressive they are. That's a key to the diagnosis. So some of you might say, well, why isn't it a hemophilic pseudotumor? It's a female. So that mitigates against it pretty heavily. And usually hemophilic pseudotumors have one big coalescent, rocky, sometimes calcified, ossified lesion, not this sort of multifocal pattern of pressure erosions. But it could have crossed your mind. What about gout? Gout is famous for producing eccentric, overhanging erosions, but no synovitis. And it's a 56-year-old female, not a very good demographic for gout. In fact, there's so much tissue here, yet very little to no inflammatory reaction in the joint. So the differential diagnosis really is limited to PVNS. Patient had a valgus episode. He's 68. She is 68 years old. She's got posterior tibial tendon pain. Her arch is collapsed. It collapsed a year ago. Her pain is from the medial arch to the ankle with limited range of motion, swelling, weakness, stiffness, and popping. Let's start out with our sagittals. We've got 2 of them. So in our anatomic search, I only briefly mentioned the plantar fascia. Very few people have a totally normal plantar fascia if they've been on the earth for more than 50 years. So if they don't complain of heel pain, I don't really comment on it other than to say plantar fascia unremarkable. You know, even if it has a little swelling, I dismiss it. But it is in my search pattern. And this patient has another variation. You saw the os naviculare type 2. also called the synchondrotic osnaviculary, which can produce osnaviculary syndrome. Sometimes the os trigonum can get really big and become inflamed or edematous, and in dorsiflexion get trapped or compressed or irritate the flexor hallucis or swell the capsule, and the patient gets os trigonum syndrome, also known as posterior tibio-talar impingement syndrome. This can happen also if you fracture the lateral talar process. This is known as a Shepherd's fracture. You can also see it with a bifid or bipartite os trigonum. This patient does have a component of irritation that's happening back here since the os trigonum is irregular, there's swelling, and it's a little bit edematous. For now, pay no attention to this osseous structure in the Achilles, most likely an enthesophyte that broke off due to traction. The footprint of the Achilles looks okay. I'm scrolling back and forth, and there are a couple of other more advanced structures that I look at. For instance, I'll look at the short plantar ligaments between the calcaneus and the cuboid. I'll look at the articular surfaces as part of my search pattern. Yeah, there's some midfoot arthritis, which we see commonly in middle-aged men and women. There's a little bit of capsular swelling at the calcaneal-cuboid articulation with a penetrating erosion and maybe even an old chip fracture. So scrolling around, there's a lot that you can stumble on. I also use the sagittal to evaluate the distal plantar fascia to look for plantar fibromatosis, which occurs down in here. But this patient doesn't have it. Now, this curious cystic lesion some of you are probably going to ask me about. What do you do with that? Well, here's what you do with it. Incidentally noted in the distal tibia in a subcortical location is either a fibrocystic or a chondroid lesion, most compatible with a fibrocystic inclusion, like a fibrous cortical defect, or a small subcortical enchondroma or chondral rest, requiring no further follow-up. That's the end of that. Okay, so we're still scrolling along, and we have identified an os subtibiale as opposed to a fracture, because fractures usually aren't round. So now you've seen an os naviculare, an os subtibiale, and an os trigonum. So everything is just peachy. No, it's not. We have our friend Dick, but where's Tom? There's Tom. Tom looks like he's been eating a little too much. And we can't follow Tom anywhere. So we better check Tom out in the axial projection. Oh, we'll take this one, the water-weighted one. And we're perpendicular to the course of Tom. There's Harry, there's Dick. Where is Tom? No Tom. Tom is up in the leg. Let's keep going. Now Tom comes back right there. There's Tom. Now, most posterior tibial tendons do not tear at their insertion, maybe 1 out of 100. So if you see some swelling here, don't get too excited. It's usually either tendinopathy or just traction. This tissue is the spring ligament or the calcaneonavicular ligament. It's swollen because Tom is gone. And if Tom is gone, who is going to bear the responsibility to keep the arch from collapsing? The spring ligament. So the spring ligament is under stress. That's why it's swollen. Let's go back. See if there's any way we can pick up any semblance of Tom. We can't. It's off the screen, so now you have to do an MRI of the leg because this has to be fixed. So they got to pull the tendon down. Chances are they're going to have to graft it or sew it to another tendon. Sometimes they'll sew it to the flexor digitorum, but in order to know how high to make your incision, you got to find the proximal end of the tendon. So this patient is getting a leg study. While we're at it, just to be safe, let's make sure that the peroneus longus and brevis are okay. They are, but the patient does have another little accessory tendon right there, don't they? There's the peroneus brevis, there's the peroneus longus, there is the peroneocalcaneal tubercle. So that little accessory tendon attaches to the peroneus longus. How do I know it's not a tear? Because there really isn't any consistent inflammation around it. And I can follow it back a ways, all the way up to the top, without any inflammatory reaction. So there's quite a bit of variability as to the behavior of these low-lying accessory tendons, but you could easily get fooled by them. Most peroneus brevis tears are split tears. They're not round tears. So they wouldn't look like this. They would look more like this. They kind of get split in the middle. And then you might see two tendons that are very slit-like on either side, separated by some inflammatory tissue in the middle. Our anterior group is fine. Our posterior group is fine. And this patient, unfortunately, will have flat foot. Now, we may not be able to appreciate that because they're lying down, but the calcaneus is rather straight. So, conclusion. Massive posterior tibial tendon rupture beginning 3 centimeters proximal to its insertion with diastasis and retraction into the leg, necessitating evaluation of the proximal end with MRI of the lower extremity. Number 2, no navicular anomalies. Number 3, the remaining flexor tendons are intact. Number 4, incidentally noted, accessory peroneus tendon or peroneus quartius tendon. Number 5, generalized soft tissue swelling and diffusion. Number 6, signs of mild ostrigonum syndrome. Number 7, mild midfoot arthrosis. Now, some of that in the conclusion you could bury in the body, like the mild midfoot arthrosis. That doesn't need to be in the conclusion. Even the spring ligament swelling, I would put in the conclusion. Left ankle pain and swelling, limping after wearing a boot or cast. The patient is a 60-year-old female. Let's go right to the sagittals. Maybe pick an axial. Well, let's pick the water-weighted axial. We'll make them bigger. Okay. 1, 2, 3, 4. Let's check out 1. Maybe I magnified it too much. 1 has some peritendinitis, not peritendinitis with tenosynovitis, because there's no synovium around the Achilles. It's surrounded by a fibrous sheath called peritenon. So there's a little bit of peritendinitis, but the Achilles is intact. So that's 1. 2, problem. We'll come back to it. 3, Tom, Dick, and Harry. They're okay. There's your spring ligament. 4, There's Tom, Harry, Dick, and the peroneus tertius. They're okay. Let's go back to our peroneus. I'm going to pull down the axial T1 and blow it up. Actually, it's a T2, but I want to get a better look at the bony architecture of the fibular groove. I want to see if there are any spurs or if it's convex backward. It is convex backward. I also want to see if the retinaculum right there is injured. And it is. It's not ruptured, but there's a little tiny rent in it right there. That's problematic because that may allow these tendons to be hypermobile. There's also a little thorn right here, which is where the retinaculum attaches. So you always want to look for that thorn. And we go from top to bottom. First of all, up high, the peroneus brevis looks awfully strange. Here it's kind of linear. Okay, I could live with that. Maybe it's just compressed by all the fluid. It's a little signal anterior with some compression by the fluid. Some more signal, some more signal. Now the signal is in the center. Now it's in the center. Now it's kind of hard to tell. There's some signal in both tendons. Now the tendon is making an inverted V. There's the V. So I don't mind in plantar flexion if the peroneus brevis does this. I don't mind if it makes an inverted V over my peroneus longus. But what I do mind is if the peroneus longus is here and my inverted V now splits and there is a separation at the apex. Now that hasn't happened yet, so maybe it won't happen, but it did. Together, apart. Together, apart. It's like scissor kicks. That's a split tear. What's a split tear? A split tear is when you have torn a tendon through and through, both surfaces. What's a delamination tear? Intrasubstance or only one surface. So this is an official split tear. How long is it? Well, we can measure it. Starts there in the retromalleolar region. We would say our peroneus brevis has a retro and inframalleolar split tear, and then we could count slices. 1, 2, 3, 4, 5, 6, still torn, 7, 8, 9, 10, 11, 12. All right, maybe it stops at 12. 12 times 4.5. It's about a 6 centimeter long tear. It goes all the way almost to its insertion on the base of the fifth. Stops just shy of it. And a lot of that tear is intrasubstance, isn't it? So if they just went up and fixed and repaired this part, they'd be in trouble. Because down lower, there's a tremendous amount of intrasubstance material that has to be scooped out of there to allow the tendon to be sewed back together or grafted. You know, you might use fascia lata or palmaris longus or some other tendon tissue. Now, when you have such severe extensive disease, you've got to be looking at your peroneus longus because sometimes they will coexist as tears together. Not this time. The peroneus longus is intact. One major difference between the two, well, there are many differences, is that the peroneus brevis is usually an atrophic split, whereas the peroneus longus is usually a hypertrophic globular tear. So they behave differently. But as you know, the brevis goes down to the base of the fifth. The longus is going to curl over towards the medial aspect of the foot. It's going to insert on the first, and it has innumerable cuneiform insertions too. I'll demystify and demagnify it for you so you can see it. There's the peroneus longus, and you don't have to memorize the insertion of the posterior tibial tendon because it inserts on everything. But its main insertion is on the navicular. But it gives off quite a few different fibers to the cuneiforms and to some of the other bones of the foot. So that is one big, giant, 6 centimeter long, complex, split and interstitial cystic tear of the peroneus brevis with sheath distension, period. Number 2, injury to the superior peroneal retinaculum. 3, intact peroneus longus. And that should do it. The rest of it can go up in the body of the report.